to start this afternoon with Manzur Morshed Patwari, and he is a Fulbright Humphrey Fellows from Emory University, and he's also a senior program manager at the BRAC. So he has over 11 years of professional experience in organizations such as VRC and Novartis, and he also led a very large-scale project involving the COVID-19 response and digitalization of training for community health workers. So he has a lot of experience in leveraging social media for public health in with regards to COVID-19 response, and he's going to share that knowledge with us. He is also a graduate of the University of Minnesota Twin Cities, and as I said, a Fulbright Fellow at Emory University's Rollins School of Public Health. We will also hear today from Blandine Derrick, and Blandine is currently a master's student at EHSP, and she is focusing on the administration of public health policies and programs. She has had the opportunity to gain experience conducting a study on the difficulties encountered by endometriosis patients working for a startup called Capcod, and they use artificial intelligence to detect patient and caregiver experiences and social networks. So she is going to share her experience on this topic. I'm excited to hear from both of these speakers. And we are also excited to hear from Professor Jessica Madry. Thank you for being here with us. Professor Madry is an associate professor and chair of the School of Professional Communications. And she actually has lectured with us at the UHSP. And I have to confess that part of the reason that we chose this topic for this year's event was the series of lectures that we had on communication with Professor Madry. And she really inspired us to think about this topic and to delve deeper into it. So Professor Madry is also the director of the Creative Schools Healthcare User Experience Lab, and she is doing research there in public health communications, health equity, and the medical humanities. So without further ado, I would like to allow Manzur to start us off, and he will present. He will give his presentation followed by Blandine and then Professor Madry. So we will let you have the floor. It's very nice to meet you and nice to see you in person. And I let you have the
floor. Hi, everyone. Very nice to meet you all, and very good morning from Atlanta, Georgia. So I am having a bit of difficulty presenting from my laptop webcam. So I just wanted to do a quick intro. So I have a presentation to share with you. So let me know if you can see it.
Yes, we see it. Thank you.
Okay.
Okay, so the title of today's talk is about harnessing social media to fight the pandemic. So as Liana mentioned, so I work as a senior program manager at BRAC. So it's the largest NGO in Bangladesh, and it focuses on different areas such as health, education, skills, migration, etc. And I have been working for the health program. And I was fortunate enough to lead several large-scale pandemic response projects, which are still, continuing as the threat of COVID is yet to disappear from Bangladesh. So in today's discussion, this will be the quick topic. So I already gave a little background about myself. I'm going to cover some misinformation of COVID on the internet that users in Bangladesh came across, some prevention strategies that were undertaken. I'm going to talk a little bit about how the government and NGO work together, especially in the area of social media to fight the pandemic. And since I have a bit of experience, responding to COVID and having some campaigns, so I'll be sharing some experience from my projects and other BRAC projects. So we're gonna show you some effective contents that we were successfully using on our social media. And then I am going to finish by talking about some key takeaways and the way forward. So in terms of Bangladesh, the misinformation that were floating around on social media were mostly produced by locals, and some of them were even adopted from misinformation found on other cultures. So the number one, in my opinion, would be that COVID can be cured or prevented by herbal plant. Especially we have in Bangladesh something called Kalijira. So there'd be a lot of posts saying, if you consume this, you'll be safe from COVID. There were talks about having, tea frequently, and then boiling water is effective against COVID. Another very popular misinformation was that COVID is a punishment from God. And some of you might know that Bangladesh is a Muslim majority country. And there was a lot of information going online that, if you're a devout Muslim, if you're very religious, COVID can't get to you. And a lot of and like a few religious leaders also put out some YouTube videos related to that, which contributed to this misinformation spreading. And then in Bangladesh, we had a saying that Goriber Corona hoy na, or COVID does not affect the poor. So on online, there was also information circulating that it's an urban disease, which only affects the elites. And the next one is very interesting. So there was an image of the Brazilian president floating around on Facebook, especially, with the comment of the Italian prime minister, which said, we've exhausted all the solutions on the ground, and our only hope, remains up in the sky with God. So that was kind of taking place when Italy was experiencing major COVID prevalence of COVID. And then in terms of vaccine, the most common misinformation that was floating online was that AstraZeneca vaccines, which were being procured from India, are not effective. So here are some online misinformation preventive strategies used mostly by the government. So they ran a national anti-misinformation campaign called Let's Know the Truth. And it basically incorporated different videos and posts involving celebrities and prominent personalities to dispel rumors. There's the website called COVID-19 Information Hub at the National Corona Portal. There's also Corona chatbot such as COVID-19 Response Bangladesh. There's also a mobile application. You can still find it on Google Play Store called Corona Tracer BD. And there were websites like rumor scanners, which are still there, fighting misinformation online. And you can go on this websites or apps to verify information regarding COVID. So I would say compared to Western countries, the misinformation about COVID-19 is currently not like as grave, if I may, because the government received unanimous support from large and small NGOs alike, and the online and offline massive level awareness campaigns were involving, as I mentioned, prominent personalities and local celebrities, and they were running incessantly by the government, NGOs, and private sector. So there was a real harmony and a real joint purpose in fighting the pandemic. And you can see that in Bangladesh, some of the results are evident. We have a very high vaccine uptake among the population. So over 70% of the population have already been vaccinated. So we are hoping to see the number increase in the near future as well. And also social media groups led by physicians were a major source of news for urban population. And in general, Bangladesh has a strong track record of successful health communication. Starting from the 80s, you had you had a lot of successful health communication fighting diarrhea, and then there was a mass immunization campaign. So generally, there has been a good reception about among the people as well about information that was promoted by the government and NGOs. So if we talk about some insights from BRAC, so BRAC is the largest NGO in Bangladesh, and it has been closely supported the government in the nation's COVID-19 response. And I would say, among all the NGOs in our country, BRAC, I think, played the most prominent role. It supported the government with, their campaigns. It supported with mass vaccination campaigns in the recent past. And on social media, it basically uses Facebook, YouTube, and LinkedIn. So LinkedIn it primarily uses for organizational updates, and Facebook and YouTube are the two social media that it uses for its content and to reach its mass followers. So speaking of followers, it has 1.77 million followers across all these social media platforms, and it is by far the most among the local NGOs in Bangladesh. And BRAC's social media posts to date have been seen by 28.8 million times. So here are some effective social media content that were used during the initial COVID-19 wave. So we use a lot of myth-busting videos featuring physicians. So this particular video talks about what are the symptoms of COVID-19, and it was on YouTube, and to date it had over 1.4 million views. So we also use jingle-based awareness videos featuring local celebrities and musicians. And this one is sort of like a local music in a local dialect, so which cater to the entire population. So many of you might not know that schools in Bangladesh were closed for 18 months due to COVID. And when schools reopened, our organization did school-specific campaigns during its COVID-19 response. And we partnered with Sisimpur, which is the local version of Sesame Street in our country. And we shot and aired a video aimed at our younger viewers who are school-going children. So if we talk about key takeaways, so I would say social media became the second most important source of information on COVID-19 lockdowns, after government run campaigns on TV and radio. And urban audiences also checked announcements from authorities like WHO, CDC, and from our experience, infographics got better engagement when it came to sharing information, and we are still using this to raise awareness about different other health issues. And medical experts and live sessions were really popular, and we also so many television stations also ran these roundtable discussions online during COVID, and it was very interactive with a lot of Q&As, and so those got a lot of popularity, especially during the early days of COVID. And those indicated that there was a demand in the audience for authentic source of information. So the next one is very interesting. So crowdfunding played a role in providing aid to the needy during the lockdown. So there were a lot of groups that popped up, in different localities, and those were mostly through Facebook, which is by far the most popular social media in Bangladesh. So they were mainly run by the youth, and if there was a particular neighborhood that where people needed emergency help, so like these groups played a very big role in helping them out locally. And there have been many groups on social media which have spread rumors and misinformation about COVID, but at the same time there were groups too that formed to dispel these rumors, and many of them featured prominent physicians, and they were also a good source of information about best preventive practices and just news on what was going on around the country. So you might notice that when I was talking about social media used by BRAC, I did not mention TikTok. So we all know that TikTok is one of the fastest growing social media platform out there, and it is just growing and growing. But in Bangladesh, it is still not perceived as a mainstream source of information. However, some UN agencies have already started, putting out their content on TikTok in Bangladesh, and BRAC also plans to follow suit, and there's a plan to engage the young audiences via TikTok by the end of this year. So I will just like to finish by saying that we obviously know that like social media is like negatively associated when we're talking about public health a lot of the time, but there is a silver lining. There is a potential of social media that we can harness to fight different disasters. And when like non-government organization, the private sector and the government can work together with one shared purpose, there can be a fruitful result. So that's all from me, Liana. Thank you.
Thank you so much, Mansoor, for your contribution. Thank you for your talk. It was very, very informative and interesting to hear about the situation in Bangladesh and how you were able to act so positively and to work with the government, to have NGOs working together with the governments, which is one of the topics we kind of discussed this morning about how that can come about, in times of crisis. I will open the floor to see if there was any questions. I believe I saw there was a hand up, and if you have any questions, please don't hesitate to raise your hand and we'll get to you. And while we're waiting for those who may have questions, I have a question just concerning the history of Bangladesh. Do you know if there was a history of having to deal with misinformation in the past on any other particular health topic or concern? Was this something that was really brand new in terms of having to develop a strategy to prevent it?
So I think COVID was the first time where we came up with a very comprehensive strategy. But I believe, this is only the beginning. So if we have any, crises or disasters in the future, we already have like a way forward of, how to act, especially having the social media in mind.
Okay. And you mentioned about, oh, I'm sorry, we have a question from Tiffany. Go ahead, Tiffany.
Yeah, sorry. I was just wondering if there was a particular reason as to why TikTok was not considered a reliable source of information when other social media platforms could also be prone to misinformation being shared there. And I was wondering why TikTok specifically was kind of cast aside.
Hi, Tiffany. That's a great question. So there was incidents in Bangladesh when like TikTok was associated with trafficking, and that kind of created a very negative impression of TikTok at one point of time with the government. And there was even a talk about the government banning this platform entirely. But I think, everyone is, kind of beginning to see that, this platform is not going away, and, the number of users in Bangladesh as well is, increasing astronomically. And especially if you want to cater to the younger audience, I believe that's a very viable platform. So hopefully we will be seeing a lot of, health content and messages on TikTok.
Thank you so much.
Thank you for your question, Tiffany. And actually that is kind of relates to the other question I had, which is if you saw a difference in the age, like an age difference in terms of the uptake of the vaccine because of this avoidance of TikTok, or if you think, in general speaking, the uptake was uniform in all the different age groups in Bangladesh.
Just wanted to say that the Bangladesh government just recently began vaccinating the 5 to 12 age group in schools about a month ago. But in terms of vaccine uptake or like vaccine hesitancy, the youth has been been successfully targeted through like social media, especially because they are the one who are mostly using those in Bangladesh. So naturally they were able to target those population group more effectively.
Thank you so much. Do we have any other questions from the audience? I would also like to just hear what your thoughts are, what the situation is in terms of regulation of social media in Bangladesh. I know you mentioned about TikTok being considered as initially as a new ban, but are there any type of general regulations in Bangladesh that you know of that govern social media use?
I am aware of the fact that the government requested Facebook to omit like certain posts on social media that was spreading misinformation. But Facebook is by far the most popular social media platform in Bangladesh, followed by YouTube. But you know, just to answer your question, like sometimes the government you know, like tries to address, you know, the missing like fake news pages, but you know, like in 2022, like we don't really see a you know, lot of those pages, you know, being like very prominent if you compare to the early stages of the pandemic.
Okay, thank you so much. And we have a question in the chat box. Is there any stakeholder from religious community that supported your activities?
So I'm really glad you asked about religious communities. So I ran a project in Bangladesh called Community Support Team, and a major component of that was working with different faith-based organizations. So we collaborated with leaders from Muslim, Hindu, Christian, and the Buddhist communities. And one very interesting thing we did was to create these short videos about, you know, best practices and, you know, messages saying that, you know, it is not against your religion to get vaccinated. You know, you have to, no matter which religion you hail from, you have to ensure that you and your communities are safe. So these messages were published online, like these videos on YouTube and Facebook, and we got a lot of, you know, we got a very good response from our communities through these videos.
Okay, thank you so much for that response. If there are any other questions, yes, we have one more. Is there any national policy implemented by the government of Bangladesh for social media?
So as a NGO, like when I can just tell you that whenever we are publishing some information regarding preventive messages, if you know it's something new, like we do get it vetted by the Directorate of Health Services, like DGHS, under the Ministry of Health and Family Welfare. So, you know, when, you know, COVID first hit Bangladesh in March 2020, so all the materials we were designing, you know, both, you know, online and offline. So initially we got that vetted through the government, and then we were able to publish it.
Okay. Thank you again. If there are any other questions, if there are no other questions, I should say, I will say thank you once again for your contribution, for presenting to us the situation in Bangladesh and how you worked to combat misinformation and to promote best practices in public health with regards to the pandemic. We appreciate your time with us today. And I'd like to invite you to stop sharing so that we can present, we can allow Madam Derek to present her topic for this afternoon. Thank you so much.
Thank
Hello,
you.
Badin. Nice
Hi.
to see you. So
Okay,
you should be able to share.
so up. So hi everyone. First, apologize my English because it's been a long time since I've been presenting in English, so maybe it will be a bit difficult for me. So I'm going to explain the topic of my thesis, which was the use of social network in the implementation of targeted public health programs. So we use the chronic disease endometriosis, which is for now poorly understood. So first of all, I would like just to talk about what is real world data. So it's data that are not collected in an experimental setting, for example, randomized controlled trial. So they are generated in the course of routine patient care, and therefore they reflect current practice. In my case and in my internship, we were analyzing social media. So just to be sure, we are always using open data sources, so which means that they are usable by all companies, and which means also that there is no risk of re-identification of patient when we are using messages, for example, coming from social media. So Capcod, it's a French startup specialized in innovation in the medical field. So it collects testimonies from patients and caregiver on social networks in order to objectify the realities of patient healthcare pathway. For example, quality of life, difficulties encountered, and things like that. So you can see that there are lots of targeted population, for example, patient, caregivers, and then we can analyze what they're saying on social media. So its main goal is to highlight patient voice using artificial intelligence method such as natural language processing. So those algorithms, they allows to analyze unstructured data, which is like, for example, free text or comments on social media, to make it more structured, and then we can analyze it. So just quick reminders that currently health data on social media are not yet recognized by the French health authorities. So in Capcod, we believe that social media is a powerful patient-centric tool. So it provides insights about, for example, patient sentiments, what they think about their treatments, about their diseases, but also about caregiver struggles and pain points. We also can find healthcare professional perception, so it can't be ignored. And the main goal of my thesis was to understand whether social network analysis could be useful for public health decision makers in chronic disease management, but also at a larger scale. So the question was, can the use of artificial intelligence in the analysis of patient experience on social networks be useful for the implementation of targeted public health program? The first objective was, is endometriosis a public health matter, but we won't be talking about that today. Just to remind you, because it could impact the understanding of the result parts, endometriosis, it's a chronic gynecological disease of women of childbearing age, and in which the endometrium, which is the tissue that lines the inside of your uterus, grows outside the uterus and can colonize other nearby organs. Those two other objectives were the usefulness of artificial intelligence as an innovative approach for public health, and also to compare difficulties encountered by patients using the algorithmic approach and the face-to-face interview, which is a reliable method accepted by all public health researchers and also about health authorities nowadays. So a bit about how did we manage to do that. So first of all, the social media listening. So we used a three-stage extraction and filtering strategy to obtain a data set of reliable patient messages. So caregivers were totally excluded from the analysis. So first of all, we're extracted from the web, of course, always public data. On more than 20 different sources. So it could be Facebook, Twitter, YouTube, but also like specific medical forums, such as Baby Center and lots of different sources. So then the first data set was 11,825 messages, and then we were applying a filter to be sure that at the end we were having only testimonies from patients. So, for example, we deleted irrelevant message, for example, talking about animal diseases, but also we put a filter with a political lexical field, because during the time of the study, which were January 2020 until January 2022, in France, the authorities were writing the report on the proposal for a national endometriosis strategy. So then we deleted all those messages, and the aim at the end was to have only messages from patient with endometriosis. So then we applied the algorithm called difficulties, and this algorithm, it classifies messages in which patients are expressing difficulties and unmet needs into predefined categories. And then it can give a statistic about how each category was frequently found in all the data sets. So then the face-to-face interview methodology, which is like quite simple. It's just, I did 6 interview of patients with endometriosis from several age. I also interviewed 3 healthcare professionals. Then of course, I just transcribed the interview on a standardized grid to be able to analyze each interview uniformly. And then the second step was the more interesting part, which we try to conceptualize each topic that were mentioned by patient in order to compare them to the statistic we find in the social media listening. So it's like big categories you will see just after. So what did we find? On the social media listening, we'll find, first of all, difficulty present through all the patient elsewhere healthcare pathway, which means, for example, psychological impacts, but also difficulties related to their sexuality, for example, pain during sexual intercourse. But we also find difficulties of a desire of pregnancy, or potential, they were potentially worried about their infertility, and it could impact their self-esteem. Then we find the second one was linked to the pathology. For the endometriosis disease, the difficulties linked to the pathology is mainly pain located in several parts of the body. So then, there's the main statistic we find thanks to the algorithm that analyze all the data sets. What is important to see is that the algorithm didn't find any difficulties related to the remission or to the end of life death, which is really interesting, because it means that it could be reliable because it's in accordance with the pathophysiology of the diseases. So then what we find about the face-to-face interview, so the ranking of difficulties is not the same. The first one is treatments. The second one is impact on patient social background. So this is kind of normal, because during the face-to-face interview, patients were just saying once that they were in pain, for example, difficulties related to their pathology, but they were really more talking about the difficulties they find in their social background. For example, difficulty to go and do some sports, difficulty related to their professional work, also difficulty with their family and things like that. So that's why we find 29% of difficulties in that category. So now, if we compare both, what is important is that mainly social media listening, people were talking with strongest word. They were really impacted in their daily life, but the statistics are not quite the same, but it can be explained. So the common factors, for example, in the difficulties present through all the patient care pathway, all in both methodology, patients were talking about difficulties linked to their infertility, and it was kind of the same. Also, on social media listening, they were more talking about, for example, difficulties linked to their sexuality, whereas in the face-to-face interview, they were not talking about it like at any time. So if we compare the two approaches, we can say that social media listening is like, it can be a good thing for patients because they can ask questions, they can have also virtual relationship with other patients. It can also allow themselves to talk about taboo subjects, and it's freeing themselves from a certain shyness, like speaking in front of someone can be sometimes hard for people. So also it was a less time consuming analysis. So it was really less time consuming compared to the face-to-face interview. So the only problem is like patient can express themselves in a limited number of words at a given time in their life. So we don't have really the context of the disease, the context of their story. So sometimes it's what a bit, the opinions are much more clear cut, and the difficulty is the only aim of the message. So compared to that, the interviews, like they allow us to understand the context of the disease, the impact on their life, but also to see the evolution of patients' thoughts and emotion during the interviews. So we can understand with the face-to-face interview a strong implicit psychological damage, for example. But what we can conclude is that there are two complementary methods, and it allows different type of personality to express themselves. In social media listening, like we got a lot of people talking, maybe they won't be able to speak in a face-to-face interview. So now, is it a useful tool for public health? So I think that social media is a way of expression for patients who have questions and are looking for answer. For patients who feel disregarded by health authorities, but also by their healthcare professional. So if we assume, of course, that all the messages we find were true, they are useful for patients who have suffered from poor management and discrimination, for example. So they can find new experiences and also alternative method of care, and it become an empowerment tool for patients. So it's in total adequacy with the strategy, the current strategy in France, for example, about empowerment and a patient-centered approach. So, however, the face-to-face interview, it's a method that tends to turn to people who have already learned to live with their disease and are okay with that. So it can allows us to see more details and things like that. However, in other countries now, social media data are recognized. For example, the FDA write a report about the recognition of social data. So maybe we believe that in France it will come later, but it needs to be proven as a reliable type of data. So for me, the main things, it's we need to train public health professional to manage that type of data, because it's we need to have a critical thinking and to understand all the issues about artificial intelligence, but also the way we're collecting data, the way we're analyzing it. So just to be sure, I would like to tell you a bit more about limitation about social media and all the rest. So the limitation of social media, first of all, the missing data. For example, we analyzed 2000 something messages, but for example, we only have half of the patient telling their age. So we don't know really in social media, people are not always saying, hey, I'm 24, I'm 25. So it's missing data. Also, people expressing their disease on social media are always more negative. The messages found in social media were really negative compared to the one we have in the face-to-face interview. And also there is misinformation, which is a big problem. So we don't know if messages are true. Also, we only analyze public data, which is kind of normal, but we are not exhaustive about all the messages we can find. For example, on Facebook, you get private pages, so we don't know. Maybe it's not generalizable to the population, because we all know that younger you are, the more likely you are to talk about on social media. And also there's lots of difficulties linked to the artificial intelligence. For example, the algorithm, they can't see irony or human behavior and emotions. So this is why we always need to have a project manager looking at the data and then doing quick review and then analyzing and then saying the insight and things like that. So it won't be the only way for in the future, I guess. And also media and news can influence what they are talking on social media. For example, in our study, the volumetry was much higher when they were writing the report, because like everyone was talking about it. The face-to-face interview, it's a known limitation, the perception. I did the recruitment of patients, so maybe it was not exhaustive at all. And also we should have interviewed a lot more patients. And so for me, what next steps? Well, my study in general should be done at a larger scale. We need to interview more patients, but the time constraint where we won't have time to do it. But I think it's a beginning of the recognition of a useful tool for public health decision maker. But for now, nothing is proven. So we need to like do this study like in other language, because my study on social media was only about French people talking in French, but we could have done it in a lot of other countries. We also need to see if for other diseases, which are not chronic disease, for example, rare disease, will it work? So it's the beginning of a larger research, I think.
Thank you so much, Blandine. Thank you for that very interesting and informative talk. I must say, I personally, this is the first time I'm hearing like details about a study like this. So I'm sure that there may be questions from the audience about what Blandine has presented. I just wanted to find out what you think in general is the future in France. Do you think this is a tool that will become more and more prevalent here in France?
Well, my study was only about public health matter and things like that. But for example, about misinformation and COVID, the social media listening is really useful and has been really useful during the pandemic. But I think that's, well, it's also really useful for pharmaceutical companies, because we can see where patients are not really well treated or something like that. I think if authorities want to continue in the real world data analyze, it could be really useful, but it will depend on the French strategy. The health ministry will choose, in fact, I think.
Right. Okay. Do we have any questions from the participants? Yes, we have a question in the chat, and the question is, does social media listening apply to all of the platforms? So Facebook, YouTube, TikTok, or is there one specific platform?
No, we use an extractor screening all the platforms. But for example, if no one and if not any patients are talking about endometriosis on Facebook, we won't be collecting messages coming from Facebook. But usually we are screening all types of platforms: YouTube, Twitter, Facebook, but also like Doctissimo. Well, it's a French site. I don't know if you know it. But only if it's public data. If it's private, we won't be able to collect testimonies from there.
Okay. I do. There is a question from Tiffany. Go ahead, Tiffany.
Yes, I was just wondering because I know on social media also people talk a lot, first of all on TikTok, but also on YouTube through a video. And I know it can be more difficult to access that data because you would need an algorithm to kind of understand what has been spoken and then understand even more the content of what has been said. And I was wondering if you think that maybe in the future this could also go into search policy of just data listening and social media listening.
Yeah, for now, we're only checking comments. Like, you know, there's your YouTube video and then there's comments. So maybe in the future, for me, in that type of machine learning methods and artificial intelligence method, it's just the beginning. It's going to be more and more precise, more and more reliable, for a lot of things. For now, oh, I don't know if it's, I'm not a data scientist, so I don't know if it's possible, but at Capcod, we are not analyzing video, for example, but maybe in the future. But the thing is, the problem would be, is it a patient talking in the video? If it's not, for us, it's not interesting because we are really focusing of someone saying, hey, I got this is the side effect, for example. I say, but if it's someone talking to, oh yeah, I know that endometrial, this could be blah, blah, blah. We are not looking at those messages because knowing that misinformation is like really present on social media, we just want to focus on patient describing their pathway care. So that's why.
Thank you very much.
Thank you, Tiffany. We have another question in the chat, which is there any policy, I'm guessing in France, related to social media listening?
Policy meaning like
government policy, I would imagine.
Well, the general data protection regulation allow us or not to use the data. For now, I know that the rights reports a few times ago about real world data, but there's no real policy. Like they are just all saying that, oh, it could be interesting. Let's see what's we can see in real world data in general, but there's no there's like for example patient reported outcomes. So now in France we wanted to see in the point of view of patient what they think about, for example, hospitals or their patient management and things like that. So it could be useful in that way, and they are trying to say, hey, what if we are looking on social media? It could be a way to prove that this hospital is great, this one not. But for now, I'm not sure because I'm not a specialist, but I'm not sure that it exists for now.
Okay, thank you so much. I imagine this is something that will be evolving in the future. And I just wanted to know, so your focus was on endometriosis, and you mentioned, of course, the use in the pandemic, but do you have, can you give us a sense of any other chronic conditions where this kind of social media listening has been used recently?
Oh yeah. So in my 6 months internship, I worked on a lot of topics. Breast cancer. We work on asthma and asthma in sports. So the focus was how to help patients with asthma to do sports, and is it interesting? We also worked on depression. People were also, my colleagues were working on a lot of things. We work on COVID, we work on rare disease, we work on I don't have the name in English for all the disease, but like there's, in fact, in about all the diseases, you can work with that. We just need to check before, are people talking about it on social media? And then if they are, then we can analyze everything.
Okay, thank you so much. Are there any other questions? We have one more question. While collecting While collecting data about a health condition like endometriosis from social media, does that exclude patients who may not have access to social media and hence may not get a true picture of endometriosis experiences among the disadvantaged?
Yeah, if I understand well, that's what I was saying. It's not generalizable to the population because, for example, people having no access to internet, no access to social media or to a laptop, thing like that, we can't see what they're thinking about. But the thing we say is that we're analyzing large data sets. So maybe we are not screening all the population, but we try to compensate the fact that we're not with the big data set. But of course, the big problem about social media is, for example, elderly people. We can't have their insight about the disease, but also people in sometimes other countries or in France, like that have no access to internet. It's a real problem, in fact. Yeah.
Okay, thank you so much. So if there are no other questions, I'd like to thank you so much for your contribution. We really appreciate learning about this topic. It's brand new for me, and I'm sure for many other people. And we look forward to see what the future holds in social media listening. And now we will invite Professor Madri to say a few words based on what we'll be discussing over the past hour. The floor is yours, Professor Madri.
Thanks, Nina. I've actually got a few kind of tips and tricks. And if you've been in class with me before, you know I like to kind of throw out giant fireball talking points because I find this stuff to be quite interesting. So what I'm actually going to do right now is just give a little bit of a talk about the relationship between social media and public health communication, because that is ultimately what we're talking about here. And from Manzour's presentation, it was more of a kind of direct to consumer front end kind of look at the way in which social media and public health communication kind of interact. Excuse me. And then with Blandine, it was a little bit more of a like back end look through the listening tools, which are also really, really interesting and problematic in their own way. But I'm gonna share my screen for a second here. And you know, I mean, I think that if we think about, let me just move this to this. Can you see that my little us on the side there? Is it cutting off my screen? Or does it say so? Like, am I on the side of the screen here, or can you everybody see?
Yes, I can see clearly the blue rectangle. Right,
but you can't see yourself.
No.
Okay, good. Okay, it's just because there's a little thing on the side here for me. So is social media and public health in an abusive relationship? And, you know, I think if we think about the ways in which sort of democratic communication happens, we as public health professionals want to hive off the messages that we make and somehow protect them from any sort of tampering. And the reason that I wanted to sort of think about this is because last year I ran a public health campaign in conjunction with a public health unit around vaccination. And I think I probably spoke about it in class, but it was called Vax and Snacks. So we paired with a public health unit in the city of Toronto in a neighborhood that is, I mean, it's called like, what, I don't know, it's like a little slice of the four corners of the world. Like there's 80 different languages that are spoken in this community. And, you know, there's a good deal of information, but a good deal of misinformation that spreads among sort of micro communities in a major cosmopolitan city like Toronto. And so I thought, how best to go about this than use community leaders and food, because I do study food and food policy on the side, to create a vaccination campaign. And we looped in a sort of catering collective from the community. And so that's what Vax and Snacks was. It was an after work from 7 to midnight. It's like 7 p.m. to midnight. We offered snacks that were familiar to everybody in the community. And, you know, we used kind of community leaders in that regard. And it was great. It was widely successful. What ended up happening, though, is because we had a very sort of outward facing social media campaign, right? We had a Twitter account. We were looped in with the city of Toronto, was this. So on the right, on what you'll see on the screen, on the left-hand side was our actual public health campaign Twitter poster, and we posted on Facebook and, you know, TikTok and all that. So it gave the location, it told what we were vaccinating. We gave any sort of pre-reg information or transportation. People need to be transported to the site. We offered that. And then you'll see on the right, sort of towards the bottom half, but also on the top half, that our very nicely designed communication campaign was co-opted by a sort of, I guess, a misinformation group, which is a nice way of putting it, advertising for a future late night pop-up COVID-19 euthanasia clinic. So you can see they use the exact same model, right? The exact same color palette. I think that they advertised for that we were somehow going to inject spongiform encephalopathy pathogens. You know, we offered apparently a complimentary mass burial, and we were somehow linked to the Canadian Prime Minister's office. So, and this was done, I don't know if you noticed at the sort of last, the last name on the bottom is the Ontario Civil Liberties Group. So this was done with the kind of under the guise of sort of freedom, you know, democracy, civil liberties. So some of these big words that have a lot of traction among people, it got co-opted like this. So what I want to do right now is think a little bit about the very root of what we're trying to do in public health communication by using social media. And we do it often in the name of objectivity. We are giving the objective truth to people. And because we are, let's say, like scientific officials who've been appointed by governments. But I think it bears thinking about and bears repeating that objectivity is not a kind of black box that is impermeable to other people's opinions. Objectivity is just a name that we give to a set of practices. It's just a way of doing things, but it is not, to a lot of people, the truth. It might be to us as medical professionals, but it does not mean that just because we say something is the objective truth, or it has been tested, or it has been proven in a lab, that means it's truth for everybody. It's just a way in which we do things, and we see the kind of end game in objectivity as being, you know, untampered by public opinion. And so kind of a corollary to that, because that's important to remember, just because we say that you know, a vaccine has been tested in a lab, that doesn't mean shit to a lot of people. And that's problematic for us when we want to come at public health communication, whether it's on social media, which, as you can see, is very easy to tamper with, and very easy to spread misinformation. And I think that what we forget, right, is the virality. We're very familiar with viruses and how they spread, but we talk about something going viral on social media, and it's exactly the same model, right? That stuff moves. It's very, very easy to retweet or to repost, because all you need to do is tap. And many of the kind of misinformation engines have bots for that. People aren't even at the helm of that, right? That retweeting is happening automatically. But to think about this notion of objectivity and what we do, and I think that oftentimes we position ourselves as maybe a little bit top down when it comes to public health messaging. Like, we're going to tell you what's what. Well, we're competing with the likes of, let's say, Hollywood stars or sports figures, right? This is what's happened certainly in the last few years. But we're not imparting anything inherent. If misinformation is being presented objectively, it competes, you know, with, I think that should actually say incorrect information. This should actually say incorrect information. Oh, sorry. No, it does. If misinformation, it's cut off on the side of my screen. If misinformation is presented objectively, then it competes with us with correct information. And you can see that in my example, they took the correct information and then repackaged it, but made it look exactly the same. So it's hard for people to discern what's truthfully coming from the Toronto Public Health Agency and what's coming from some sort of random bot or, public health communication is, and this is what we, I think, don't like to hear all the time, but it's political communication. So the media is going to set it up as somehow controversial and debatable. So we have to be prepared to defend, and this is a strange position to be in, but we have to be in a position to defend why we think something is the case, why the truth is objectively the truth, why widespread testing, or why one injection out of hundreds of millions of injections that goes poorly for somebody or that has deleterious effects, why that's actually not to be of concern to the public. Because what does the media do? The media will see one case as somehow applicable to across the board. But we're in a position of having to defend why that one case is actually not statistically significant. The public doesn't understand what statistically significant is a lot of times. And yet they're the one that the media will focus on. Or that a misinformation generator will jump on as somehow the one to be concerned about. So the media is going to set public health communication up as controversial and debatable. And, we've got to remember that politics is about democratic argument, but that's not such a great model for public health. And so, thinking about public health as a moral authority, and medical scientists would be then, in that case, the new politicians, and maybe this is not what you signed up for. Public health professionals and medical scientists are going to be subject to moral attacks. And I think that what we need to remember is when we're working within public health, we need training in what to do when we've been attacked, whether it's on social media or Twitter, or, our agency has somehow, again, been co-opted and rebranded as some sort of euthanasia clinic. What do we do in that case? And is it the problem that our messaging from the get-go is an issue? And then what do we do so that we can kind of buffer ourselves against that? And so there's some strategies. I'm going to replay this here because I don't think it's going to be cut off, although I will minimize myself here. Some strategies for public health messaging in social media are, we need to be accurate. And inaccurate, we need to take what is the most up-to-date, scientifically sound information. And this is the problem too, with the very nature of something like a virus, or even something like endometriosis, or the very nature of science and medical research as a whole, is that it always changes. I was talking to my kids yesterday about, the paradigms of science, and they apply. If we think about what we were doing to treat patients 50 years ago versus now, it's shifted widely. Or what we believed, to be scientifically true 50 years ago to now. Accuracy is really, really tricky. So we're kind of in this, we're in this giant leaky boat, and we're constantly bailing out the water of inaccuracies because we're trying to keep sailing forward. And so being accurate is really tricky. And to say that the most up-to-date information is what we're delivering is really crucial. In addition to that, we need to be really clear. And by clarity here, it's not about presenting more information, but about packaging that accuracy in ways in which your audience is going to understand. And so, what we need to do is actually get as sort of public health professionals training in like graphic communication, right? Visual communication. How do we take a whole bunch of data and distill it into one infographic that the public is going to be able to go, oh, I understand. And part of that clarity and accuracy is what I call incrementality. And it's because we're in this uncomfortable position of being political communicators right now. The best way to be both accurate and clear is to nest a current or a new message that you're going to blast out in social media, is to nest it in something that they already know and understand and accept to be true. And that's what I mean by incrementality. You move from what you know your audience knows to then something new. So it's not a wholesale change in messaging. It's we've already accepted that I'm going to just use vaccines because, right? We've already accepted that vaccines have been pretty damn good at wiping out polio. Now, something like COVID-19 or even like, the human papillomavirus, right? These are not polio, but we do know that if we can demonstrate to the population that vaccines have worked in these other scenarios, your audience is already halfway there. So the incrementality is just showing them one step further that vaccines do work and they will likely work in this current situation. So that's what I mean by incrementality. Take something that they know and present them with something new, because you've already brought them along with the known part. Kind of within that, your audiences require a bit of research on your part. And I said, know their positionality. And I'm not sure, well, I should hope that you've been trained in the sort of positionality of your audiences from a public health standpoint. But, when you're doing any sort of messaging in public health, you need to know who your audience is and from whence they've come. Okay. And it's not just age or culture or location, but also the kind of histories of who these people are. And their relationships with public health become really, really important when you think about how to tell a story for them or how to give a message for them. Because I think that what we oftentimes forget is that any sort of public health messaging to audiences actually requires you understanding first of all, it requires making up a bit of a story where your audience is a character in that story. That's where the public imagination comes in. But that story needs to have resonance within the positionality of that audience. You need to understand what, and I'm going to, again, I use my kids as an example all the time, right? What my 14-year-old son, who lives in a city, who comes from a sort of multicultural community, who, watches TikTok sometimes, who's got a phone, but who also goes to like a gigantic public school where there's an interesting group of like kind of powerful, like anti-vaxxing sentiments, right? So he's getting news from his mother, who is like, works in public health, but also news from kids at school. And so how does that competing information create a bit of cognitive dissonance for him? And then how do you combat against that in the sort of social media campaign that's going to, like, how do you hook somebody like that? In addition to that, and this comes to my last point on the right, sometimes social media is not digital. We talk about social media as though it's this thing that we hold in our hand all the time because we're always wired. But, social media for a lot of people is more social than media. And word of mouth in community groups is actually incredibly powerful. And so nestling in community leaders, which, we've talked about, right? Mansoor talked about this as well, is, social media is not just the voice of the apparatus in your hand or the screen in front of you. And so we often sometimes forget that the kind of analog nature of social media, gossips and yentas and people talking in the community were the first Twitter. And that's I think something that we need to start thinking about and leveraging when we talk about social media. People still get together. And I think more so now, after 2 years of being on screen exclusively, I think we're going to see an uptick in the social media part, where we're talking to each other in person as the world opens up. And that can have some really long-lasting effects. And maybe we need to think about revisiting the analog version of social media. Okay, so that's what I have today. I don't know that there's going to be any questions. I think that if there's a takeaway message, we just have to remember that our objective truth is going to be in competition. And I know it's part of our professional ideology, but it's just a set of that. Sometimes people don't see it as anything more than a set of practices that we're just giving a name to. It doesn't impart anything inherent. And that's why incorrect information, as long as it presents itself in the same model that we use, it's going to be in competition, and we're going to be in that combative stage a lot of the time.
Thank you so much, Professor Madri. I had a question. I wanted to get your opinion on. Do you think that, in general, based on what you said, this, with regards to the pandemic, definitely we have been in public health forced to be more reactive instead of proactive? And do you think there's a way forward where we can and should be more proactive in the way that we address public health issues on social media?
Do you mean reactive to misinformation?
Yes, I do.
Okay, so here's what I know. And sometimes I know things anecdotally, not necessarily from a research standpoint, but when you're reactive to something, you're generally on the defensive. And to be on the defensive to the outside world means that you are somehow, like somebody has found your sore spot. And so I don't think that reactivity actually does anything from a sort of power structure standpoint. It puts us on our back feet, actually. It makes it seem as though we're on the defensive, which we should never be in public health. And so I don't think that reactivity is actually going to do anything for our stature and our believability. I think that I would rather see an avalanche of proactivity. Yeah, that's my feeling.
Okay, thank you so much. We have a question from Tiffany.
Yes, I was just coming back to your point. Hello, Professor Madri.
Hi.
About knowing your audience, and especially considering that we are talking about social media where everything can be shared not only on the same platform, but also on different groups and on other platforms, and how the audience that we may have targeted our message to can evolve very rapidly from one group to another. And how do we manage this, considering that it's ever evolving?
Yeah, I mean, this is the problem. And this is not just a problem with public health messaging, but it's a problem with the current fluidity of any sort of messaging right now, is that you don't know where it's going to go, or who it's going to go to whom it's going to go. And so, you have to remember that you can only do the best with the information that you have at any one moment. And if that messaging reaches an audience that's not yours, or your intended, because there's no universal audience. I think a lot of times in public health, we, the word public means that we're working towards everybody. But I actually think that that's a real limitation to the way in which we can do our work. And I actually think that micro-targeting is actually much more effective than having a universal approach to public health. So it's like mini publics. And I think maybe, just by adding, how I like words, right? By adding the S to the end of public actually reframes it a little bit. It's public's health. And that's not possessive. It's like there's many different publics that we need to talk to. And so, for example, if we think about both an analog and a digital kind of social media campaign, if you're trying to target 14-year-old boys to get them vaccinated for HPV, not girls, boys, because we're doing everybody now, right? What does that look like versus 14-year-old girls? And whether that goes out into the world or it gets memed by the 14-year-old boys or like made fun of or whatever, who cares? They've got it on their radar. But that's an example of a small, sometimes like using a really, really deep dive audience analysis before you set up that campaign, knowing that that's not going to go to my grandmother. And that's cool. That's good. And if it, like I said, if it goes out and it gets memed and whatever, that's fine. In fact, sometimes I think that we don't use that memeing enough in social media when we micro-target. So it's the kind of knowing that your audience is not a generalist audience ever. And if it goes out there, fine. But let's focus on who you're trying to get at and really target your words, your messages, your images to them. I was, to my point about the kind of euthanasia clinic, we were really honored. Like we were pissed off at first, but then we were really honored. It's like our graphics were really nice. Our messaging was really clear, and that's why someone stole it. And, the public health professionals didn't find it funny, but the communication person in me knew that that was actually a really good sign. So again, micro-targeting is I think the key, and thinking about not a generalist audience, but your smaller audience, tailor it to them. You're never going to reach everybody. And if it goes out there in that kind of triplicate and quadruplicate and somebody, flashes it forward, because let's just say that my mother, who doesn't have Twitter, but we created a really nice campaign for 14-year-old boys about HPV, that maybe made some sort of, silly sexual innuendo or whatever, but it got them to the clinic. And my mother ends up seeing it somehow, because someone shows it to her. She's not the audience for the vaccine, but she may then go to her grandson and say, "Did you see this?" Yeah, I saw it, and I got the vaccine. So it's strange in the ways in which it can actually come back to the audience as well.
Thank you so much. Thank you so much, Professor. We do have a question in the chat, and it says, in your perspective, at a national level, who will be the face of public health communication? I don't know who asked the question, and I don't know where they're from, because that's important. Yes, could the person who asked the question please let us know who you are and where you're from?
And while they're answering, I'll just, at a national level, I think it depends on the country, but we had the kind of, in some countries, it's the Surgeon General. In the United States, it's often the Surgeon General, or you've got the director of the National Institutes of Health. We had, in Canada, we had Dr. Theresa Tam, who was the kind of chief public health scientist. The problem with that, and this is from my time working in the media and working with a lot of scientists and doctors, is that they're not always the best talker. And so I think that at a national level, the best strategy, which is not really the question that they asked, but the best strategy is to have a kind of knowledge mobilizer who works alongside and with and in tandem with your public health director at a national level. And then they become the kind of, okay, so let's just say Teresa, Dr. Tam, who was Canada's. If Dr. Tam has a message for everybody, she gives that message to our public health spokesperson. And that spokesperson translates the message. That's really what knowledge mobilization is and knowledge translation is. Translates that message, knowing that you're going to be speaking to everybody on a national level. Do I think that the actual doctor themselves should be the spokesperson? Listen, Anthony Fauci was amazing, but he'd had a lot of training and he's a very outward facing kind of guy. Not all countries have that. And that, because that was a real luxury for the United States. Did he get a lot of blowback? Yeah, still, but he was able to handle it. Not all countries have an Anthony Fauci. And I actually am not certain about who the next Anthony Fauci is going to be in the United States, but those are tall, it's a tall order to fill. So I think that making sure that there is a knowledge mobilizer or a knowledge translator who works alongside that doctor, or that public health professional, if they're not good on camera, or if they're not good on Twitter, or, then you need that buffer, because people will just tune out. And I think they did a lot of times in Canada because we just didn't have a compelling figure. Remember, this is somebody who, when you've got a major public health issue, is trying to encourage people to action. And if they are boring, uncompelling, incomprehensible, people are just going to switch off because there's 1,000 other channels to go to.
Thank you so much for that response. I definitely can see the parallels to how Manzoor spoke about having local celebrities as well as doctors participating in their campaign. And so I guess you need both sides to kind of reach your target population appropriately. So thank you so much for that, that response. Do we have any other questions from the audience? If not, I would like to say a very, very warm thank you for your contribution today, Professor Marjorie. It's always a pleasure to hear from you. We look forward to seeing you in Paris, hopefully, at some point over the next year.
I think mid-October. Yeah, I'm coming the 17th, 18th, and 19th of October. Yeah.
We'll make sure to say hello to you, and we thank you again for taking your Saturday morning to spend a little bit of time with us.
Okay, I'm caffeinated, so that's all right.
Okay, we're just gonna take, if we would ask everyone to turn on their videos if it's possible, because we just want to take a small picture to commemorate this event. So if you are able to, please turn on your cameras. And Hein, will you be taking the picture?
Different, it will be more feasible in different computer.
Yeah, I can take the picture.
Thank you, Tiffany. Thank you all, guys. Just a minute. Perfect. Let us know when it's done, Tiffany.
I think I got everyone in the picture.
Oh yeah, I see it. Thank you so much. Thank you again, Professor Madri. Have a great Saturday.